I don't know if the effective post-it. Thanks so much, Kelly, for that introduction.
You're welcome.
And it's a pleasure to be here. There's been a lot of development in the ILD space over the past few years, so I'm really excited to share some of the updates. I'll start off with my disclosures. I have done some work with Boehringer Ingelheim, and we'll be talking about a couple drugs that they produce, so nintedanib and nerandomilast. But we will be talking about other drugs as well. So hopefully it's a balanced presentation. Over the next 40 minutes or so, we'll be reviewing the new screening recommendations for interstitial lung disease in systemic sclerosis or scleroderma. We'll go over some recent clinical trials for treatments. And then we'll kind of put it all together in terms of a general approach for treating ILD. So as you're all probably familiar, interstitial lung disease is essentially anything that impacts the interstitium. And the interstitium I like to think of as the saran wrap layer that kind of wraps around all the lung structures and prevents it from being a floppy structure. So it provides that structural integrity. The interstitium itself is very thin when it's normal, but when there's inflammation or scarring, you could imagine that it then starts to impede gas exchange, so things like oxygen transfer into the bloodstream. Interstitial lung disease is an umbrella term for hundreds of different types of ILDs. This is just a figure highlighting some of the bigger buckets of ILDs. There's certainly more than this. So for example, there's exposure-related ILDs that can be secondary to drugs or environmental exposures. And then you've got the autoimmune related where scleroderma falls, and then the bucket where we're not quite sure about a specific etiology. This figure shows the distribution of some of these ILD subtypes within the US. And we see that 20% of people with ILD have idiopathic pulmonary fibrosis, which is a subtype which you may have heard about. It's one of the more common fibrotic ILD subtypes. Hypersensitivity pneumonitis is the exposure-related ILD. And then about 20% are autoimmune related. So previously we used to say connective tissue disease, but we're now using a new term called systemic autoimmune rheumatic disease, or SARD for short. So SARDs refer to chronic rare conditions where the immune system mistakenly attacks the body's own connective tissues and organs. And it can cause widespread inflammation, pain, and then potential damage and destruction of joints, muscles, skin, and affect vital organs like the lungs. SARD is much more all-encompassing compared to connective tissue disease or CTD previously, so that's why we've kind of transitioned to the new terminology. So SARDs includes things like systemic sclerosis, it includes inflammatory muscle diseases, and then all the way to vasculitis, where you've got inflammation of blood vessels. And another important reason that we've kind of moved towards this SARD category is that when we study these rare diseases by themselves, it's really hard to recruit for studies. So having a broader bucket allows for more clinical trials. In terms of the epidemiology for systemic sclerosis, so there is a range of 14 to 44 patients with systemic sclerosis per 100,000 people in the US. It's more common in females with a ratio of 4 to 1, females to males. And ILD is more common in the diffuse type of systemic sclerosis compared to limited. So the differentiation between diffuse and limited is really just the amount of skin involvement. So with limited, it tends to just affect your distal extremities, so the hands and the feet, whereas with diffuse, it can affect everything, including the trunk. Systemic sclerosis affects many organs. So this is the prevalence of the organs that are affected. So essentially everyone has skin involvement, muscle involvement, including joints. And then the digestive tract is heavily involved in or heavily affected by systemic sclerosis. And then 65% of people with scleroderma will have lung involvement. And then about 23% will have a heart involvement, mainly pulmonary hypertension. So why do we care about ILD in scleroderma? We know that it is more prevalent with 65% of people having lung involvement. It's also been shown that ILD can affect quality of life and daily function, and importantly, it can affect survival. So this is a graph that shows the survival over 10 years based on lung function. So the FVC, or forced vital capacity, is a certain parameter on the pulmonary function test, and the higher the number, the better. So if we categorize people based on kind of mild, moderate, severe disease, in the top, those who have a forced vital capacity over 75% predicted, their 10-year survival is about 87%. But this can drop all the way down to 55% for those with severe interstitial lung disease with an FVC of under 55%. So to summarize, systemic sclerosis has the highest rate of mortality of all connective tissue diseases. The overall 10-year survival is 62.5%, and the leading cause of death is interstitial lung disease. All right, so how do we diagnose ILD in scleroderma? So the three most common symptoms are fatigue, shortness of breath, and cough. But many patients are also asymptomatic, which is important to note, and I think justifies why we should be screening people even if they may not necessarily have symptoms. So in 2023, the first guideline for ILD screening and monitoring in the SARS population was published, and this was a joint publication between the American College of Rheumatology and American College of Chest Physicians. And this really allows for a standardized approach to screening and monitoring ILD, and it facilitates the co-management of the condition between rheumatologists and nephrologists. In this document, they recommend screening for ILD if people have high-risk features for interstitial lung disease. Within scleroderma, these are some of the high-risk factors. So anti-SCL70 is a type of blood test and antibody, and if it's positive, there's actually a higher risk of developing ILD. Those who have diffuse skin involvement should be screened for ILD. Male sex, if you're earlier on in your disease, so within 7 years of a non-Raynaud's symptom of scleroderma, and then if you've got elevated inflammatory markers. One important thing to note is that just because one doesn't have these risk factors doesn't mean that the person will not develop ILD. These are just some features that are known to increase the risk. And so screening isn't limited to people with just these features. So this is the diagnostic or the screening algorithm for interstitial lung disease in all comers with a SARD. So if there's an increased risk for interstitial lung disease, then people should go on to be screened with a pulmonary function test and a high resolution CT chest. If there are no risk factors for ILD, then at a minimum, patients should be asked about the presence of symptoms, so the fatigue, cough, shortness of breath, and then on physical exam, listening for crackles. After people are screened with the pulmonary function test and the CT scan, if interstitial lung disease is not identified, then people should continue to be kind of screened through history and physical exam, and then maybe even re-screening every now and then. However, if ILD is diagnosed, then we go into the monitoring phase, and typically we'll monitor every 3 to 6 months initially to ensure things are stable, and then the monitoring becomes less frequent, but we monitor with PFTs, pulmonary function tests, 6-minute walk tests, and then the CT scans as needed. So these are kind of the main tests looking at lung disease in scleroderma. The echocardiogram is used to identify pulmonary hypertension, or at least screen for it, which should be done annually. All right, so pulmonary function tests, You love it, you hate it, but unfortunately, we kind of make all our patients do it. And in interstitial lung disease, what happens is with the scarring and the inflammation, it's more difficult to fully inspire. And so you end up with lower lung volumes. And the lung volumes are reflected in these measurements of the forced vital capacity and the total lung capacity. There can also be a reduction in gas exchange, which is reflected in the diffusing capacity. So these are the main numbers that we look at on your PFTs. For ILD in general, it's really important to order the right tests, especially with imaging. So this is to highlight that point. So this is a normal chest X-ray on the left. Black is normal lung where it's full of air and the air is black on the X-ray. The heart's in the center. And then someone with interstitial lung disease, their X-ray looks like this in the middle. And it's, not normal. There's a little bit of haziness, but it's really hard to know, is that haziness because of scar material or inflammation from an infection? But on CT scan, we could really tease this apart. And so CT chest is really the way that we should be diagnosing ILD, and it should not be done through a chest X-ray. Within CT chest, there's different types of protocols. And so for interstitial lung disease, people should be getting what we call a high resolution CT chest. And an HRCT chest essentially takes thinner slices and more slices through the lungs. And then the way that it's reformatted, it provides a higher resolution. And so especially in the screening period where we're trying to pick up really small abnormalities, we want as high resolution as possible. So this is the same patient with interstitial lung disease who underwent a standard CT chest. And you can see maybe there's some abnormality there, but it's much clearer on the high resolution. So the HRCT chest should be used for screening. These are just some examples of what we tend to see in ILD and scleroderma. So normal for comparison on the left. So the heart again in the center, and then the black is normal lung, and the white lines are blood vessels. On the right with is a person with scleroderma and interstitial lung disease, and we see that there's this hazy appearance that is usually reflective of inflammation or potentially some scarring. And then you have kind of these dilated airways that are being pulled open from scar material. The other CT finding that's specific for scleroderma is what we call a patulous esophagus. So normally the esophagus is a very tiny tube, but in scleroderma, the esophagus ends up quite dilated. And so you could compare, it's much bigger, and it doesn't come through particularly well, but you could actually see some food particles within the esophagus. So that kind of explains why people often have reflux and regurgitation symptoms. The other test that I like to do is the 6-minute walk test. And this is where people walk for as far as possible for 6 minutes. And then we measure the blood pressure, heart rate, and oxygen saturation at the beginning and end of the test. And then we could compare the distance walked to the expected value for someone of similar height, weight, age, and sex. And it provides a lot of information. It gives a sense of a person's functional status. And then it also flags whether we should be screening for home oxygen. So the home oxygen assessment is slightly different from the 6-minute walk test. Initially, we get people to walk, and then if their oxygen levels drop below 88%, then the oxygen is applied and we get the person to walk again. In order for oxygen to be funded in British Columbia, there needs to be 2 things that are met. So 1, with the oxygen levels have to improve. And then 2, the walk distance also has to improve and meet a certain threshold. All right, so we'll move into treatment. When I think about treatment, I like to frame it in terms of the pathway of pulmonary fibrosis. So at the end of our breathing tubes, we have a structure called alveoli, which is where the gas exchange occurs. In the alveoli, it's lined by what we call epithelial cells. And in fibrosis, there are kind of 2 major things that happen. So One is that there's some type of injury to the alveolar epithelium. And the second thing is that there's an abnormal repair mechanism. So too much scar material is laid down, which then thickens the interstitial. In scleroderma, the antibodies are produced and go around and cause inflammation of the structures, including the alveoli. So that's the injury. And so we could target the injury through immunosuppression. And then with the abnormal repair mechanism, we could target it through antifibrotic therapies or anti-scarring therapies. So let's go through some of the trials for immunosuppression. So many years ago, cyclophosphamide was the first-line therapy for scleroderma and interstitial lung disease. And then there was a big study called the Scleroderma Lung Study #1, where people were randomized to receive either cyclophosphamide or placebo. And they received cyclophosphamide for a year, and then they were monitored for another year off the treatment. And they found that people in the cyclophosphamide arm ended up having improved lung function compared to placebo, less shortness of breath, less thickening of the skin, higher quality of life, and they found that the lung function effects on the lung function were maintained over the full 24 months of study. So if we look at that in kind of a graphical format, well, the forced vital capacity is on the y-axis, and many of the interstitial lung disease studies, we use the forced vital capacity as that primary endpoint to see if something's considered effective or not. So higher numbers, positive numbers are better. People who were in the cyclophosphamide arm had an improvement, so 49% of people had an improvement from their baseline FVC. So they were in this positive zone compared to 26% in the placebo arm. If we flip that, the 74% of people in the placebo arm ended up having a drop in their lung function over the study period compared to only 50% in the cyclophosphamide arm. So overall, cyclophosphamide did better than placebo. But the difficulty with cyclophosphamide is that it's an IV medication and it has a lot of side effects that can be quite severe. So that led to the scleroderma lung study #2, where they looked at the drug mycophenolate compared to cyclophosphamide. So this study looked at using mycophenolate for 2 years compared to cyclophosphamide for 1 year. And then they followed patients again for 2 years. And they found that both drugs resulted in improved lung function, shortness of breath, and skin disease over 2 years. So we could see that the forced vital capacity, again, on the y-axis, that there's this improvement in both the cyclophosphamide and mycophenolate arm. And the mycophenolate arm, they were essentially similar. One was not better than the other. So mycophenolate was felt to have the similar positive effect of cyclophosphamide, but much fewer side effects and better tolerated. So this has kind of replaced cyclophosphamide as the first-line therapy for scleroderma ILD. The other medication that is commonly used in scleroderma is rituximab. So this is an IV medication that tends to be given every 6 months. The recital study looked at rituximab compared to cyclophosphamide in all comers, so not just scleroderma, but in SARD ILD. And they found that both treatment arms resulted in improvements in the forced vital capacity at 24 weeks, as well as improvement in quality of life. And the benefits persisted when they followed up to 48 weeks. So the conclusion was that rituximab was associated with fewer adverse events than cyclophosphamide, and it also reduced the need for steroids over the 48 weeks. All right, so then going into antifibrotic therapies. So nintedanib became available to treat scleroderma ILD after this landmark clinical trial called the Census trial in 2019. And this study included specifically people with scleroderma who were kind of earlier on in their disease course, so within 7 years of their diagnosis. And they had to have moderate interstitial lung disease on imaging, as well as mild to moderate abnormalities on their breathing test. So in terms of the change in FVC from baseline, in the placebo arm, over 52 weeks, the average drop in FVC was 93 mils over that year. But those who were on nintedanib, they still dropped, but at a lower amount of 52 mils. So the difference was 41 mils, which is a relative reduction of 44%. And if we kind of look at that trended over the 52 weeks, we see that consistently over this time, people with who were in the nintedanib arm had less lung function decline compared to placebo. Now, the study wasn't designed to look at comparing combination therapies, so nintedanib with mycophenolate compared to the others, but they provided the breakdown of people in these different treatment arms. And based on that, it's kind of exploratory data that then requires kind of further studies that are properly designed to answer whether the combination of nintedanib and mycophenolate is truly better than each of these medications on their own. So if we look at people who were taking nothing, no mycophenolate, no nintedanib, their annual lung function decline was 119 mils. People who were just on nintedanib, no mycophenolate, their lung function decline was less at 63 mils. Those who were on mycophenolate alone, very similar to nintedanib alone, so 66 mils. And then those who had a combination had a drop of 40 mils. So it kind of suggests a signal that combination therapy is probably maybe more effective at minimizing the decline in lung function. But again, we kind of need a proper study to look at that. Now, nintedanib unfortunately has a lot of potential side effects that tend to be gut related. So in this study, people who were in the nintedanib arm, 75% of people had diarrhea. And this is, not negligible because, scleroderma can affect the digestive tract. So you're kind of already prone to GI issues. The other kind of common side effects were nausea and vomiting. So just something to keep in mind. But this included people who had really severe diarrhea and those that had very mild diarrhea and manageable. Over the past few years, we've also had this new term called progressive pulmonary fibrosis. And it came about because we were realizing that patients with certain interstitial lung diseases that weren't necessarily idiopathic pulmonary fibrosis kind of behaved similarly. So they were progressing. And so, would it make sense to actually treat them with an antifibrotic? And so PPF refers to someone who has a non-IPF diagnosis, such as scleroderma-related ILD, and demonstrates progression. And progression is based on a combination of worsening symptoms, breathing tests, or imaging. And so this led to studies looking at antifibrotics in PPF, and the first one was the INBUILD study. So this study looked at, again, nintedanib versus placebo, and it wasn't specific to scleroderma, but it encompassed a lot of different ILD subtypes. So this is the breakdown. So it included people who had exposure-related ILDs, unclassifiable. It had 25% autoimmune ILDs, and the breakdown for scleroderma was 6% in this study. And so when we take all comers, if we look at kind of the graph on the left, this is the overall population, and those who were in the placebo arm, their drop in FVC was 187 mils in a year. Those in the nintedanib arm, it was reduced to 80 mils. Okay, so that was a relative reduction of 57%, or the difference between these bars was 107 mils. Now, if we look at those with autoimmune-related ILDs, the average drop in the placebo arm was 178 mils, And then this was reduced to 75 mils with nintedanib. So a difference of 102 mils. So overall, nintedanib slowed the rate of annual rate of decline in FVC compared to placebo. They did provide kind of a breakdown of the different autoimmune ILDs in this in-build study. So if you recall, for the pooled autoimmune related ILDs, that difference was 102 mils. And if we look at scleroderma, it was on average 120 mils, but the confidence intervals, we call it, was a bit wider. So there was actually a couple patients who actually had lower or greater lung function decline in the nintedanib arm compared to the placebo. But overall, on average, it was 120 mils difference in terms of less lung function decline. And then the tolerability in the broader cohort was better for nintedanib. So the diarrhea rates were 63%, but again, still a large portion of people who could potentially experience diarrhea, nausea, vomiting, loss of appetite. All right. And more recently, we've had another antifibrotic medication that has had a positive study published earlier this year. It's called nerandomilast. And this was a study in progressive pulmonary fibrosis. So they looked at 2 doses of nerandomilast compared to placebo, so a 9 milligram twice a day, 18 milligrams twice a day, and then placebo. And about 6% of patients in this study had scleroderma. So this is the result. So again, they looked at forced vital capacity over 52 weeks, and the placebo arm, their FVC decline was 165 mils. Those who were in the 9 milligrams twice a day arm, their FVC decline was reduced to 85 mils on average. And then in the higher dose, 18 milligrams twice a day, it was 98. And then we could kind of just see the lines over time, and we see both the 9 and 18 milligram arms have a slower lung function decline compared to placebo. But I think it's important to note that you'll kind of notice with all these antifibrotic studies, there's still lung function decline. Whereas if we compare it to the studies with mycophenolate, rituximab, there was actually stabilization, if not some improvement. So I think that's a really important distinction between immunosuppression versus antifibrotics. So the takeaway from this study is that nerandomilast slowed disease progression at both doses, and this was generally consistent across the different ILD diagnoses, including autoimmune-related ILDs. The adverse events leading to treatment discontinuation were similar across the different arms. Interestingly, nerandomilast had less diarrhea compared to nintedanib. So in the higher dose nerandomilast arm, 36% of people experienced diarrhea compared to that's the 60% with nintedanib. And the main limitation with this study is that people who were on mycophenolate were actually excluded. So we just have to keep that in mind, that the results for this study don't necessarily apply to people who are on mycophenolate. So to put it all together, alongside the screening and monitoring ILD guideline that was published in 2023, they also put out a treatment for ILD in SARDS document. And so in terms of scleroderma, for first-line ILD therapies, we think about mycophenolate, rituximab. I didn't talk about tocilizumab, but we don't use it as frequently compared to mycophenolate and rituximab. And then we think about adding in things like nintedanib. There are some rare instances where maybe we start with nintedanib first, but for the most cases, we start with immunosuppression first. And then they just kind of highlight a strong recommendation against steroids, particularly in scleroderma, because it can increase the risk of renal crisis. So I just wanted to have a couple slides also thinking about other comorbidities that can affect the lung in scleroderma. So the digestive tract is commonly involved in scleroderma, and things like reflux can lead to aspiration, and it could aggravate the underlying interstitial lung disease and potentially lead to progression. So we really want to have the digestive tract issues well managed. The other comorbidity is obstructive sleep apnea. It's reported in up to close to 70% of patients with ILD. And untreated OSA or sleep apnea can actually make reflux symptoms worse. So if you've got, you know, difficulty sleeping, maybe snoring, you don't wake up refreshed, you're constantly tired throughout the day, it might be worth being screened for sleep apnea and then being treated for it with something like CPAP. All right, this is just a general approach to gastrointestinal issues in scleroderma. So the supportive measures to prevent a reflux, such as chewing food well, making sure that your head of the bed is elevated, ensuring there's several hours between your last food intake and sleep. If you have reflux symptoms, then it's important to be on anti-reflux therapies. So usually with proton pump inhibitors, some common examples are things like Pantaloc, esomeprazole, and then you could think about add-on therapies and sometimes surgery. And then if there's difficulty swallowing where food gets stuck, or maybe pills or food are coming back up undigested, then that might point to a motility issue rather than a reflux issue. And so there may be medications to help with motility. And so it's also really important to get referred to a gastroenterologist because they'll be able to do the upper endoscopies to look at the anatomy and help guide therapies. All right, so we kind of whipped through things really quickly. I'll end with a conclusion. We'll have lots of time for discussion. So we went over the new screening guidelines. People with scleroderma should be screened through clinical assessments, pulmonary function tests, and CT chest. We went over data on immunosuppression trials as well as antifibrotics, and then put it together in terms of a general approach to treating ILD, usually with immunosuppression as first line and then the addition of antifibrotics. All right, thank you for your attention and happy to take questions. And you can see some in the chat. Maybe I'll pop it open. I might stop sharing here first. Oh, it's just that. Oh yeah, so I guess for questions were you could ask it in the chat, or if you're comfortable, please feel free to unmute yourself and ask it. Oh.
I had a question about one of the studies. The one where there was two doses, there was 9 milligrams and 18 milligrams.
Mm-hmm.
Am I correct that it showed that the 18 milligram dose had a greater reduction in the FVC?
It looked like that, but statistically they were similar, but the number was a little bit bigger in terms of the drop. You're right. But overall, it's kind of felt to be similar.
So based on that, would it be more the recommendation just to take the 9 milligram versus double the dose? Okay.
Well, we don't know yet. So in Canada, it's currently under